Because I can view it full screen anyway.
Okay, good evening everyone, and welcome to our session on the basic principles of neonatal life support. It's my absolute pleasure to be joined by Dr. Kath Cooke, who is an ST5 in paediatrics, and will be leading the session this evening. This is the first out of 4 of our neonatal presentations this week. I will be running the PowerPoint slides, but if you have any questions, just stick them in the chat over on the right-hand side of the screen, and Dr. Cooke will be able to see your questions as they pop up. Okay, so over to you.
Thank you. I may turn off my camera to distract myself or introduce myself again. Hello, everyone. Thank you for giving up sunny barbecues and gin and tonic in a garden to listen to a presentation about basic principles of neonatal life support. My name is Kath Cooke. I'm a ST5 registrar in paediatrics, currently working in neonates in Burnley Hospital, being Northwest trainee myself. I'm privately mum to a toddler and keen runner. Very sore, as completed great Manchester run yesterday. I'll do my best to go through the topic, giving as many practical aspects of neonatal life support as the presentation allows. Please feel free to ask questions throughout. There will be a section for questions at the end as well. Okay, so what is your experience of neonatal resuscitation? If any, everyone, if you can just shout out in a chat whether you've seen neonatal resuscitation on one of your placements, whether you're actively involved in neonatal resuscitation in everyday life, whether you've been to obstetrics theatre, to labour ward. Anyone? Silence. That's fine. BLS training, yeah. None apart from SIM, being in theatre to observe. So that helps me a lot to try and pitch it at the right level, and involved in PZD and none. Right, we're going to try and even it out, and I'm going to try, oh, amazing, given inflation breath, I'm going to try and kind of take you through the process as the baby's born and what we do and why we do it. A little bit of theory at the very start. Aims and objectives, as we spoke, to understand the principles of neonatal resuscitation and differences between neonatal and adult or pediatric resuscitation. I'll try to teach a logical approach to supporting transition and neonatal resuscitation at birth. This approach tells us that we should first open the airway and aerate the lungs, and then, in event of anything else being necessary, provide a brief period of chest compressions. We're going to be talking about a case of a term baby only, because preterms are completely different, and they would provide excellent topic for another presentation and webinar. Next slide, please. So this is quite a busy slide, but I suppose I've put it on here to make you look at the right-hand side of it. So we know that babies are designed for the asphyxial process of normal delivery, and as a part of adaptation, baby circulation, as you can see, there are minutes at the bottom of it, of the graph. The circulation is able to continue and function reasonably well for more than 20 minutes of hypoxia. So that happens because of the primitive, if in case babies is anoxic, the primitive spinal gasping center that is in our brainstem can initiate breathing even much better than the capabilities of the normal respiratory center. This gasping can manage to inflate the lungs of the baby, and the circulation may still be sufficiently intact in the baby to distribute the oxygen first to the heart and then to the brain. And almost, this is what we would call the incredible self-resuscitating baby. If the baby is not breathing at birth, we know from the evidence of physiology that the most important task for us is to aerate baby's lungs, and you're going to hear it from me over and over again through this presentation. In many cases, the circulation of the baby will be sufficiently intact, and the lung inflation alone will be sufficient to resuscitate baby without further action. In babies who would progress further along this graph, when the lung inflation will be followed by a brief period of chest compressions, it may be enough to bring the oxygenated blood back to the heart for the heart to respond and recover. Next slide, please. Equipment. Depending on where you're going to work, which trust you're going to work, in what environment you're going to work, you're going to see many different kinds of equipment and kits. There are two main resuscitators in Britain, and one of them is pictured on the right hand side. This is the one with white background, and the one with a medical professional explaining something to there. Resuscitators are equipped in light source, heater to aid you thermoregulation, your suction, and a mixer of oxygen and in order to generate pressure to provide inflation and ventilation breaths. On the left-hand side, we have something we call Life Start Trolley, which is a trolley that enables us to resuscitate babies with umbilical cords being still intact, whether that's term or preterm baby. It's also equipped in thermoregulation. This little blue mattress on the side is actually a heated mattress when it's on, and has suction and everything that resuscitator does, but in compact form and on wheels. The two photos in the center are actually the examples of kits that midwives use at delivery, at home delivery. And as I said, the equipment will vary across where you work and across all the areas and across all the countries. So it's important for you, if you are going to be involved with neonatal resuscitation, to know your kit as you would in any other part of medicine. Next slide, please. A word on delayed cord clamping. I'm not sure whether you've heard or seen it before, but it's very fashionable, should I say, a thing in Word of Neonates and Obstetrics, a phrase in Word of Neonates and Obstetrics, and it is delay of cord clamping carried out more than a minute and more after birth of the baby. The benefits are, there are plenty of them. There are immediate and long-term benefits. I mentioned preterm and low birth weight infants as well on this slide, because I wanted to underline how important it is to reduce their comorbidities after birth. So in terms of immediate benefits in our preterm babies, it would significantly decrease the risk of intraventricular hemorrhage, late onset sepsis, and necrotizing enterocolitis, and also decrease the need for immediate blood transfusions, surfactant administration, and prolonged mechanical ventilation. Full-term infants would receive adequate blood volume and birth iron stores, which then 2 to 4 months of age on, when physiological anemia kicks in, improves the HB and hematocrit, and also improve iron status up to 6 months of age. Long-term benefits for preterm or low birth weight infants are also related to physiological anemia, but there is quite strong evidence for improvement in neurodevelopmental outcomes, especially in male babies and in the babies born extremely preterm, so less than 28 weeks of gestation. All these benefits come with no effect on maternal bleeding or length of the third stage of labour for people passionate about obstetrics and gynecology. And the trials suggest that less blood-filled placenta shortens the third stage of labour and also decreases the incidence of retained placenta. I'm not a specialist myself, but that is what Royal College of Obstetrics and Gynecology quotes in their guidelines. You would want to probably, in aspect of our neonatal care, wonder whether there are many contraindications to perform delayed cord clamping. And amongst these, we can mention that there are very few actually. Requirement for immediate resuscitation, problems with cord, such as cord snapping, incision on cord, or limited cord length, although that would be the cord length doesn't have to be an issue. Full stop. And maternal problems such as placental abruption or early separation of placenta, which would massive bleeding mum can definitely affect baby. Uterine inversion, monochorionic twins, and this is because the risk of placental vessel anastomosis may result in draining blood from twin 1 to twin 2 during changes in pressure during delayed cord clamping, and any maternal concerns such as postpartum hemorrhage, shock, or seizures would be also listed amongst contraindications. Next slide, please. This algorithm is NLS algorithm, and you will see it through your career very frequently, even if you don't choose paediatrics as a career, which I would wholeheartedly encourage you to do. It's simple, it's linear, and tells you what to do. So if at any point you're in a first responder and you've not done NLS, this chart will be visible somewhere to aid you before your help arrives. Reassuringly, most of the babies will require support only from airway and breathing point of view, and this is what I would say should kind of make you feel less scared about neonates and resuscitation. Next slide, please. So what do we do when baby's born? We try and do things in linear and systematic manner, and your initial assessment will guide the level of support and indicate whether the delayed cord clamping should be done as well. You dry and cover the baby and put the hat on. You assess the situation from a point of view of very well known to us algorithm ABCD, and that doesn't change at all. If you have facility to keep baby still attached to mum during your assessment, you can dry and stimulate the baby, and also ensure that after your initial assessment, along as you go, baby is warm and covered after that. If you are giving, but then after your assessment, you should bear in mind, and as I said, I will repeat that a lot, that if you're giving support to the baby, there's no point in giving inflation breaths if you haven't opened the airway. There's no point in giving chest compression until your lungs have been inflated, and there's no point in giving drugs until air and oxygen is available within the lungs. And that means that you're able to get oxygenated blood to the heart via chest compressions. So as in every resuscitation known to medics, there is no breathing before airway, circulation before airway, and drugs before breathing. You do everything in linear manner. Next slide, please. This is a funny, I always smile when I see this slide, because the initial actions you have to take are really simple. All the babies are small, as simple as that, and all the babies are born wet. And because they have large surface area, they get cold very quickly. So your first action will be to dry and cover the baby and conduct your assessment throughout. The warm, dry towels are usually available in labour ward. They will be also available in theatres and actually in most places, unless the baby is born out of hospital. But thermoregulation is your friend and is very, very important. During this time, you assess, and we're going to speak about the assessment in a following slide. But you should also remember that most babies need very simple things done very well, and making sure that the temperature is adequate is very important. Next slide, please. So how do we start? If you're in a hospital, if you imagine we're in labour ward, baby's being born, and we did quick assessment after baby was born. Midwife was happy with the baby, and we did delayed cord clamping and other way around. Baby's been born. We start the clock. Baby cried. We did delayed cord clamping. Midwife brings baby to resuscitate, dries the baby, and then we assess the baby, or we're able to assess the baby with cord remaining intact, depending on where you are and whether your working conditions allow you to do that. If you're not happy with baby stops breathing, there is slow heart rate, at any point of your assessment, you need to ask yourself, do you need help? If things are not straightforward, so the worry arises as the baby had been born, it's really useful to know later how long it took after birth for the baby to respond, and that's why we start the clock. If we've already said before that it's really important that baby stays warm, and that means we need to dry them. We need to apply the hat, and while drying the baby, applying the hat, we assess how the baby is. If the baby is clearly unwell, call for help at once, and ask yourself all the way through your resuscitation whether you needed help at any point. Next slide, please. Now let's focus on initial assessment of the baby. We assess 4 things. So just imagine baby's been born, whether it's attached to the cord or delayed cord clamping has been done, or you see baby on resuscitate. You pay attention to 4 main things. First one is a collar. Second is tone, then breathing and heart rate go afterwards. Most babies will be born with really good tone and flex posture, and then these are the babies that, if you can see them from the end of the resuscitator across the room being born, there should be no problem in waiting a minute to allow the placental transfusion and do delayed cord clamping. The babies that I would be worried instantly about are the ones that will be unconscious, and they will be just floppy and limp as they're being born or taken out via C-section. The next is collar, which is not in any aspect measure of oxygenation, because most babies will be born blue, but taking first breath will enable them to become rapidly pink. And these are the babies, also you can see flexed pink, blue turning pink baby. I would allow for delayed cord clamping, but baby who would be born very pale, so we say shut down, this might suggest that this baby is in big trouble because they are in hypoxic or occasionally hypovolemic stress. Breathing, no one counts breathing, no heart rate in delivery room, but we assess whether breathing is obviously adequate, so baby is crying, inadequate, so there is a scattered work of breathing with some respiratory distress, such as recessions or abdominal breathing, or just very irregular breathing, or non-existent. And if baby is gasping, which is almost like a shudder, this is not an efficient breathing pattern, and this would be also the baby I would be very worried about. And heart rate, we assess heart rate listening to it with a stethoscope. That's the best way and the most reliable way to do it. Not many labour ward rooms or theatres have pulse oximeter handy, and it takes a time to get the trace, so your ears are the most reliable kit you have, and stethoscope. And I wouldn't bother to count the heart rate. It will be either very fast or slow, so less than 100, or very slow, less than 60, or absent. So it's just trying to assess how fast is it, having a quick listen to it. So we have colour, tone, breathing, and heart rate. So if we have baby who is turning pink with flexed tone, screaming, we can presume the heart rate is good, and delay cord clamping. If we have baby who is blue or pale, limp, there's no obvious signs of breathing, or there's very irregular breathing and has slow heart rate, that would be a baby that we would be worried about, and we would like to have them on resuscitate as soon as possible. Next slide, please. So now we go to A and B part of our assessment, because they are usually dealt together within a baby needing resuscitation birth, which is, I suppose, ever so slightly different from adult resuscitation. The first objective is to get baby's head in neutral position, and most of babies will have very large occiput, which will make the head flex and impair the airway. If we can play video.
Need to make sure the baby's not hyperflex. That could be because of a large occiput, so I might consider putting a rolled up towel under the baby's shoulders to get the neutral position, and make sure that I haven't overextended the head, because that would occlude the airway. So a nice neutral position.
Yeah, so neutral position with surface of the face parallel to surface of the resuscitator or table that baby is on. The next slide, please. Next slide, yeah. And again, you can see on the photo on your left, the chin has been lifted off the chest, and face is approximately parallel to the surface on which baby is lying, and the little picture on the right-hand side shows you the correct position, and also the situation with head with big occiput, which chin almost touching the chest when it's too flexed or too extended, and that would be the in floppy baby, the tongue would obscure the airway in that case. Next slide, please. After we open the airway holding the head in neutral position, we would come to jaw thrust. In floppy baby, not all the babies need jaw thrust, but the floppy and poorly babies will need it. Does it play? Sorry.
I'm going to put my thumbs on the baby's cheekbones, use my fingers to bring the baby's jaw forward, and then I'm going to roll the mask up and over the top, holding the mask in place with that jaw thrust to try and bring the tongue forward and open the airway.
So we are talking about situation when you're the only responder and you don't have hands to help. But as the lady did in the video, you would lift the angles of your jaw, pressing your thumbs on the cheekbones, and try and lift the jaw up to enable baby's face being in neutral position, and to make sure that we can apply the mask and give inflation breaths. So if we imagine we're in labour ward, baby's born, is floppy, not breathing, and probably has a poor heart rate, and they have not breathed yet at all, therefore the lungs will be full of fluid, and in order for us to aerate these lungs, we need to use positive pressure ventilations, and these breaths that we're going to administer will be prolonged, relatively prolonged inspiration. It's kind of the good way to describe it is like you blow the balloon for the first time, and brief and quick ventilation breaths won't work at that stage, and you want aid baby to expand their lungs. It has to be steady, sustained ventilation, as it is on the video.
And give 5 more long, slow, sustained inflation breaths. 2 inflation breaths, release. 3 inflation breaths, release. 4 inflation breaths, release. 5 inflation breaths, release. And then I'm going to reassess.
Yeah, so you could see in the video that the baby's chest was moving, and that will be one of the things that we're going to look out for. Next slide, please. Short slide about inflation breaths. As I mentioned before, we need long inspiration time for these first few breaths that are essential to ensure that adequate inflation aeration of the lungs is successful. Your success depends on the replacement of the fluid with air in babies' lungs that have never breathed before. And it's important, as you saw in the video, the lady is counting to ensure that the inflation breaths are 2 to 3 seconds long, because when you count, it's easier to stick to the routine as opposed to give too short a breath when the adrenaline is kicking in everyone, because it's a resuscitation scenario. Next slide, please. So you've given inflation breaths, and after every action throughout the resuscitation, you reassess. And does anyone have any idea what would we be looking for? What's the first thing we would hope to find after giving inflation breath? Anyone? There's a little hint in the icon. So if you click James, the answer will reveal that too. Yes, chest movement, very good. Yes, improved heart rate. That's what we're looking out for. If I get you back to the baby that has just been born, this is a baby who is floppy, not breathing, has a low heart rate because we presume that they will be poorly given they are floppy and not breathing. And we are maintaining neutral position of their head with a jaw thrust. And we've given the 5 inflation breaths and we are reassessing. So increased heart rate would be first thing I would expect if I've administered sufficient inflation breaths. Next slide, please. So we reassessed, the heart is increased and is now more than 100, so it's fast, but the baby's still not breathing. The next step would be to give ventilation breaths until the breathing of the baby is established, and we would ventilate about 30 breaths per minute until the baby takes over. It's almost like counting 1, 2, 1, 2, and reassessing after 30 seconds. Next step, please. So now, what a question for you as well. When there is, you've done your inflation breaths, and there's been no increase in heart rate. What do you think is going on? Any ideas? Yes, excellent. And there is one more answer to it. If you click James, it will reveal both. Again. So you have not inflated the lungs. So we need to revisit all the hell. We are far, if you remember this complicated graph from the third or second slide, the heart, we are far down along the line, and the heart will need us help. We need our help to respond. If you click once more, James. So how can you tell? Does anyone have any idea? How can you tell which one of these options are true? What would suggest that we're not inflated the lungs? Because that is the main answer we need to give ourselves. Yes, if you have a pulse oximeter handy and pair of hands to apply it on the right hand's chest movement, yeah, absolutely. If you click again, yeah, these are really good answers. Always look for the chest wall movement. So just to sum up what we've said, successful inflation breaths would make your heart pick up 100%, but if there is no change, we have two situations. We need to revisit our airway techniques. So ask for help at that point. Make sure that we keep baby's head in neutral position. Make sure that the mask is applied correctly. And also, if we think that we've elicited good chest wall movements, if we are absolutely sure that all these things are fine, call for help, because you may have to progress further down the NLS algorithm. Next slide, please. So once we know that the chest is moving, we would reassess, and then we would do another after our inflation breaths being successful with good heart pickup, we would do 30 seconds of ventilation breaths and confirm ongoing chest movement. And then, because we've done an action, after another 30 seconds, we would reassess. And if the heart rate still remains very slow, despite 30 seconds of good ventilation breaths, we would commence chest compression. So it's very important to be clear that the ventilation is effective and the chest is moving, because that is our only guidance to tell us whether we're doing a good job with airway and breathing, and whether we should be thinking of escalating our resuscitation further. Because if all the things we talked about are true and performed in perfect manner, and there is still no response, that means that the heart needs help to respond and the baby is in serious trouble. Next slide, please. So the logic and behind chest compressions is that you want to move oxygenated blood from lungs to the coronary arteries. It's not very far, and it won't take long. Usually, it takes around half a minute with efficient chest compressions to get the oxygen down to heart, and most babies will actually respond in that time. And this is the point when, for a term baby, we start, I should have said that at the start, we start our resuscitation and airway maneuvers in air, for term baby only. We're talking only about the term baby. When we make decision to commence chest compressions, we increase our oxygen to 100% on resuscitate. Just to contrast it with adult resuscitation guidelines, which mention and put quite a lot of emphasis on chest compressions, that shows the difference between neonate and adult thinking, because in an adult cardiac arrest, the lungs will already contain the air, and adult in cardiac arrest is not usually grossly acidotic at the time of collapse, which is the case in our babies due to secondary to hypoxia. So our baby at birth will have lungs full of fluid and be grossly acidotic, and they are in serious difficulty at that time. And massaging more unoxygenated blood around the place will do nothing. So that is why, again, I repeat that you need to make sure that your lungs are inflated and aerated first to be able to distribute the oxygenated blood from the lungs to the coronary arteries. Next slide, please. So this is another video, but a little commentary to it as well. As opposed to adult resuscitation, we are not really trying to perfuse the brain. You are trying to return oxygenated blood back to a healthy heart. In order to facilitate that, the inspired oxygen should be increased to 100% if the chest compressions are given, and that's the logic behind that. And as I said before, most of the babies who actually need chest compressions will respond with increase in heart rate within less than a half a minute. And the commentary in the video will tell you how we do it.
So I'm going to do 3 compressions to 1 ventilation breath, which is just a short breath. I'm going to use the encircling technique, so wrapping my hands around the baby, fingers touching at the back, thumbs a centimetre below the nipple line on the sternum, avoiding the zippy sternum, compressing a third of the depth of the chest, allowing it to recoil in between each one fully, and I'm going to do 15 rounds of that, 30 seconds of chest compression. So if you can give a breath to start, please. 1, 2, 3. 2, 2, 3. 3, 2, 3, 4, 2, 3.
And you continue that, providing 3 compressions to 1 ventilation at about 15 cycles every 30 seconds, reassessing every 30 seconds. The preferred technique is used, as the lady did in the video, 2-handed technique, a circling technique, but 2-finger technique is also available, and that will be on the next slide. So if you see, 2-finger technique is on your left-hand side, and your landmarks is 1 centimetre between the line between 2 nipples, not pressing on zippy sternum. So you want to press on sternum, 1 centimetre between the line connecting the nipples, and that will be the same for the encircling technique, which the lady did in a video, and you reevaluate the response every 30 seconds. If the heart still remains very slow or absent, we continue the chest compressions, but we make sure that the airway is secured, so we didn't have to worry whether our ventilation is efficient. If we have output, so if baby's heart rate improves, we would then titrate our 100% oxygen, depending on preductal oxygen saturation. That, well, in this situation, you would very much have help around, so someone can apply the pulse oximeter on your right hand side, or your right hand wrist. Next slide, please. Consideration of drugs. If as opposed to probably adult resuscitation, but then I'm not an expert at all in adult resuscitation. If drugs are necessary in neonates, the prognosis is really poor. There is no specific evidence supporting any particular order of drugs. We use adrenaline, we use dextrose, we use sodium bicarbonate, and very rarely we use volume, and that would be usually O negative blood. Adrenaline is given to increase peripheral vasoconstriction and increase systemic vascular resistance, and increase the coronary perfusion and coronary blood flow to get the oxygen-rich blood to coronary arteries. Glucose prevents hypoglycemia. Bicarbonate reverses intracardiac acidosis. And because if the circulation is at a standstill, peripheral access is pointless, we administer drugs through umbilical venous catheter that you can see being inserted on in the photo. Volume as blood is given quite often for some reason. I think that people just, if you get to the drug giving point, you try and do everything and try to reverse all the reversible causes for cardiac arrest, but it's very rarely needed. It will be needed in massive bleeding, mother placental abruption. Definitely that would be my first two to think of to give volume, but adrenaline, glucose and bicarbonate we would use However, baby would be in serious trouble at that point. Next slide, please. So our pale, floppy, unresponsive, not breathing, with low heart rate baby has been successfully resuscitated. We didn't have to give drugs, and baby is recovering. And I just wanted to touch quickly on what's next after we have resuscitated the baby. We would still continue to reassess on regular basis, preferably every 30 seconds. We would make sure that baby's temperature control is good throughout the resuscitation as well, if possible. We would prevent hypoglycemia, so we would check sugar and make sure that we don't need to treat hypoglycemia, because regardless whether it's a preterm baby or a baby with low birth weight or term baby, the episode of resuscitation has definitely used, and the stress of it has used up all the reserves. So we would like to make sure that we maintain normal blood sugar without giving some intravenous dextrose. We would inform parents on what happened and be prepared for questions. We would document everything, and documentation should be very thorough and contain times of events. That's why it's also helpful to have a timer started at the very birth of baby. Most trusts you would be working at would have a resuscitation performer, and usually there is someone scribing if there are enough people at the event. And also make sure, whether you're senior or not, to make sure that you're taking care of the team you're working with. So it's a good practice to, after any resuscitation, to have a cup of tea with the team, or just quick chat, to have an opportunity to discuss through what happened, what went well, what could have gone better, and reflect upon the events. Next slide, please. If baby didn't respond to our resuscitation, we would have careful consideration of effectiveness of ongoing resuscitation, and treat all the reversible factors in overall clinical picture. It's not a good prognostic factor. There is no heart rate at birth and still absent at 10 minutes of baby's life. They are either very likely to either die or have severe neurological disability. Babies who have not started normal regular breathing by 25 minutes of age have very poor prognosis, and stopping resuscitation is always considered and within a team, and is always made by an experienced and most senior member of the team, after exclusion of all the possible reversible problems. Next slide, please. We're going to go through some cases just to wake you up at the end of my presentation. 3 cases. Let's just go quickly to summarize what is happening. What is happening? We're having a baby that is blue, turning pink, with good tone, breathing regularly, fast heart rate. Would we delay cord clamping? Any takers? Yes, we would. If you click James, what would be the next action if you were the doctor in a room, knowing that baby's turning pink, has a good tone, is breathing regularly, can see them from the end of the room crying? Yes. Yes. And if you click James, give to parents with wholehearted congratulations. Let's go through the second case. Absolutely, give baby to mum. Baby is blue, has moderate tone, is breathing but irregularly, and yeah, absolutely. Dry baby, keep warm, skin to skin, and has slow heart rate. Would we allow cord clamping? So has moderate tone, is blue, but is breathing irregularly. On our assessment by the bedside or midwife tells you baby has slow heart rate, so 60 per minute. So that depends on where you working. If the baby is, I would allow delayed cord clamping, but only on the condition that I can stimulate baby throughout. So I would ask midwife to stimulate the baby, and what I find reassuring is baby is breathing irregularly. So as long as it's not gasping, I would say that I would allow delayed cord clamping, or make sure if I can assess baby at the very start assessing baby, make sure that the head is in neutral position. And then my next steps would be ask to bring baby to resuscitate. Yeah, exactly. Dry and cover. Open the airway, so put baby's head in neutral position. See what's happening to slow heart rate, because sometimes just neutral position allows baby to pick up the heart rate, because that's our first airway maneuver. And then if there is no difference about that on my reassessment after putting baby into neutral, put baby's head in neutral position, consider inflation breaths. Is that clear? I know it's always the one that it's like people are no or yes. I think that the presence of breathing, even though it's irregularly, and the fact that really between getting the cord clamped, that's from practical point of view, getting midwife to bring the baby over, not insisting on skin to skin, that's just off the record and practically speaking. A baby is almost a minute of age by the time they are on the resuscitate, because that's blue baby is not unexpected to be born. They had moderate tone, so they may be just a little bit shocked. They're breathing irregularly and the heart rate is there. Sometimes midwife would tell you that the heart rate is improving after stimulation. So we would still dry and cover, open the airway and see what happens. If there is no change after putting a baby's head into neutral position, you commence inflation breath as you would, and I would, whether you're senior or not, I would ask for a pair of extra hands at that point. Always ask yourself whether you need help. Next slide, please. Baby's born blue or pale, is floppy and not breathing, has slow or very slow heart rate, so less than 60. Would you clamp the cord in this baby? I mean, would you immediately clamp the cord in that baby? Yes. Yes, absolutely. Yes. And you can leave the cord on if you have the lifestyle trolley at the very, if you remember the equipment slide, the lifestyle trolley is exactly for this scenario, when you can just put baby on it and manage your airway with baby still attached. That is an option, but it's only, well, you won't see it in any of the DGH hospitals. It would be a tertiary unit. Truth to be told, if you're called, if you're crash called to a labour ward for baby who is pale and floppy, not breathing, they would have clamped the cord and commenced resuscitation at the very start, but with airway manoeuvres. So what you would try and cover this baby, you would start the clock on your arrival, or you would call for help, open the airway, neutral position, inflation breaths, and reassess, because the heart rate might have picked up and we would be in a scenario of the baby we've discussed through the presentation. Right, that's me done. Any questions from anyone? I'll just show you my face for the questions.
Okay, we'll just give them a minute or so. Just there is a slight delay on the screen, I think. Thank you very much. That was really informative.
Thank you.
And I'm just going to send a feedback form to everyone that's in the chat, or anyone that is watching later on catch up.
Is there any indication for any suction if airway maneuver and done and ventilation successful? Yes, look, so because it's a basic principle of neonatal resuscitation, I didn't think it was very relevant for that subject to touch on suctioning. Usually, suctioning is not a standard a part of airway maneuver, but there are certain circumstances that you would do that, and one of them is as you've written. If your airway maneuvers are done, your 2-person technique when you have a helper is done, there is no chest wall movement and no response in heart rate throughout. If you're competent to do so, you would have a look and try and suction, or just suction under direct vision in case there is any debris, vernix, anything in baby's mouth that is preventing that. The other thing is when baby is born through meconium, which is, again, if baby is born through thick meconium, and we are still, and it's crying, we wouldn't suction routinely. If it's having regular breathing, we wouldn't suction routinely. But if baby is born pale, floppy, unresponsive, you would still do your airway maneuvers. But if there is no, there would be no recommendation to do routine suction of meconium, but you would always bear that in mind, that if you cannot get your airway maneuvers right and there's no response in heart rate, and you're competent to use laryngoscope, because that's apart from just Janke suction in the mouth, that would be what you're looking for, whether there is any big meconium plug that is obscuring the airway, then yes, you are very much allowed to do that. But you would definitely call for help in that situation, regardless of how senior you are. Any other questions? Was that all right? Yeah, cool. Oh, I'm very pleased to hear that. So if James, you skip to summary slide, where we're waiting for questions. So just like as a summary of all that we've talked about, because it's quite a lot to process, we always start the timer, dry and cover baby. We assess the situation, our 4 things: tone, color, breathing and heart rate, which determines whether we allow for umbilical cord management or delayed cord clamping. We then manage the airway. We manage airway and breathing at the same time. We do initial inflation breaths and then ventilation breaths if we get chest rise and response in heart rate. Then chest compressions, that is after 30 seconds of adequate ventilation breaths and no response in heart rate. And then we would consider drugs, but we remember that at that point we are all in serious trouble and we need help on board, senior help on board. The algorithm, like any other resuscitation algorithm in medicine, is simple, linear, and most of the babies you're going to see will need only A and B, but done well and simply, and making sure that you're not skipping any of this. So there's no point in giving chest compressions if you're not aerated the lungs. There's no point in giving drugs if the lungs are still full of fluid. The algorithm tells you not only what to do, but also how you should do it, and it's always available in labour ward always, and it's not a sin to have a look at that during a stressful event of resuscitation. Thank you very much. There are no other questions.
Okay, it doesn't look like there are any further questions coming in. But like I said, thank you very much for giving up your time this evening.
No problem. My main resources were NLS guidelines, Obs and Gynae Royal College, delayed cord clamping guideline. And I hope I didn't put you to sleep and you will have your short barbecue. It's still bright. So, yeah. Thanks so much, everyone. Thank you.
Okay, and please remember to fill out feedback for Dr. Cooke's session. We do read it, and it's really useful for all of our presenters and our whole team that are working on these to be able to review what's kind of gone really well, but also if there's anything we can improve on. And I've also just popped in the chat a registration link for tomorrow's session, which is all about understanding the NIPE.
Oh, Phoebe's going to do NIPE. What a brave person. I'm sure it's going to be excellent. Thanks so much. Thank you, James. Thanks for your help. Thank you.